Hi everyone, in this video I'm going to talk about suicide and psychotic disorders. Starting with the suicide, um, it must be screened for in every encounter, part of risk assessment along with violent and homicidal ideation. So it must be screened for in every encounter. How would be your approach to the patient? You have to ask every patient that have you had any thoughts of wanting to harm themselves, and then you have to classify whether you feel like if it's active ideation or passive ideation. In passive ideation, they just have some death wish. They would say that currently they wouldn't have any active plan for suicide, but they would say like, I would rather not wake up, I would not mind if a car hit me. So this is passive ideation. And then we have active ideation, in which they do have a plan. They say, I think about killing myself. So for that, you have to assess for the risk then. And then how would you assess for the risk? You'll ask questions regarding their plan, regarding their intent, and the past attempts. Past attempts is the highest, the previous attempts is the highest risk factor of all the 10 risk factors mentioned here. So in plan, you'll ask, do you have a plan as to how would you end your life? And then intent, how would you actually carry out this plan? If not, why not? In here, we are looking for the protective factors for them, right? And in past attempts, we'll look for the number, how lethal those attempts were, and what was the outcome, medical intervention, were they intoxicated, and the precipitants. If intoxicated on the first approach, reassess when sober. So if the patient was intoxicated in the first approach, then you have to reassess and reassess for the risk when they're sober. And then you will assess for the suicidal ideation, onset and frequency of thoughts, control over suicidal ideation, intention, intent and lethality, access to means, time and place, provocative factors, that what makes you feel worse, and then protective factors, what keeps you alive. This is a very important question. This is from where you can start the psychotherapy and just bring them back from the suicidal thoughts. Final arrangements: have you written a suicidal note, made a will, given away your belongings? And then in that, you also look if they had any previous attempts. You also look that if it was planned or if it was impulsive. So you ask for the final arrangements, that have you talked to somebody about that, did you tell anybody about that, did you make a will? Then we know that it is like planned. Practice suicide or aborted attempts. Ambivalence: I wonder if there is a part of you that wants to live, given that you came here for help, right? And then determine the level of risk and development treatment. Safety plan. Then we are going to assess the suicide attempt. We look for setting, if it was planned or impulsive, substance use intoxication, medical attention, brought in by another person versus brought in by self to ED, time lag from suicide attempt to ED arrival, expectation of lethality, reaction to survival. Are they guilty or are they happy? Right? So guilt or remorse. Are they guilty or are they disappointed? Right? If they're guilt, if they're happy, it means that they don't really want to kill themselves. It was just impulsive, or it was just out of the situation they were in. But if they're disappointed, they're self-blaming, they're sad, will attempt more. They will definitely go and attempt more. So you have to, that is that. If they're sad after being saved, it has bad prognosis, so you have to keep them, and you're not gonna let them go. Maybe if they have still active ideation, you'll admit them. Evidence of escalation in potential lethal means. And in epidemiology, attempted is 20 to 1. Attempted to complete is 20 to 1. Females do have more attempts, but men have completed it more. Then we have risk factors. The risk factors, sad persons is also a mnemonic for the suicide risk factors. Sex, male, age more than 60 years, depression, previous attempts, ethanol use, rational thinking, loss. So were they having delusions, hallucinations, hopelessness, suicide in family, organized plan, no spouse, no protective factor, and then serious illness, intractable pain. That's why they wanted to kill themselves. So this is the mnemonic 10. And then we have some risk factors, in which starting from the epidemiology: age, sex, race, marital status, living situation, and other age. It increases after age 14. So second most common cause of death for ages 15 to 24. Highest rate is completion in person after 75 years. The first most common deaths in age from 15 to 24 is most common cause of death is road traffic accident. Second is suicide, and third is tumors. And if we see that if it's either like it's bimodal, right, increases after the age of 14 and then increases in completed highest rate of completion in persons more than 75 years. You have to remember this is more than 75 years. And then male and white people or indigenous people, divorced, widowed, and who are alone, they have no children under 18 years of age, and then stressful life events or access to firearms. Some psychiatric factors to past suicidal attempt, it comes the first, and then eating disorders, bipolar, major depression, mixed drug misuse, panic, schizophrenia, personality disorder, alcohol use. Psychosocial factors, recent severe stressful life event, and then psychiatric disorder. Mood is most associated to suicide. So whenever you were suspecting if there are mood disorders, they might have suicidal ideation too. So with the mood disorders, you have to, with especially with depression, higher in bipolar. So in bipolar, the manic, when they're in mania, and then when they're recovering, during the phase of recovery, they have most suicidal ideation. So lifetime risk in depression is 15%. So mood disorders, anxiety, schizophrenia, substance use disorder, eating disorder, adjustment disorder, conduct disorder, personality disorders, borderline or antisocial. So you have to remember with mood, the most common association of suicide is with mood. There's one more thing right here. No, I've written something on the sides. So for example, if there's schizophrenia patient, the scenario looks like schizophrenia, but they have 3 suicidal attempts. So 3 suicidal attempts means they were depressed, they had some mood association. So it might be schizoaffective. Affective means the schizoaffective is, when you have mood disorders, and in between that you have like 2 weeks or more of absence of the mood disorder, and then you have psychotic features during that time. Delusions or hallucinations for 2 or more weeks in the absence of major mood episode during the lifetime duration of the illness. And the illness is uninterrupted period of illness during which there is major mood episode, either depression or mania. So any kind of mood episode, and then 2 weeks or more it is absent, and then during that you have psychotic. So this is off topic, but just wanted to share this. All of these side notes, these come from my UWorld or ASQ Bank, or question banks. So scenario looks like schizophrenia, and they had 3 suicidal attempts, which means depressed, so it might be schizoaffective. So I just wanted to show the association between suicidal attempts and depression. So the mood is clearly associated with suicidal attempts. All right, then we have we did this past history, prior suicidal attempts, most recent attempt, family history of suicidal attempt, and completion. This also has weightage. Okay, and then clinical features, symptoms associated with suicide: hopelessness, anhedonia. Anhedonia is loss of interest, insomnia, severe anxiety, concentration is impaired, psychomotor, agitation. How would you manage? Proper documentation is the most important thing. In whole psychiatry, this is important for NAC too. You have to properly document. You have to mention that I'm going to document this. Okay, so of the clinical encounter, and the rationale for management is essential. Then we have 2 types of patients: higher risk patients and lower risk. Higher risk are the ones who have a plan, they have intention to act, also they have access to lethal means, recent social stressors, and symptoms suggestive of psychiatric disorder. So the higher risk patients should be hospitalized, should be strongly considered. Hospitalization is strongly considered. So high risk patients, you're going to hospitalize. You do not leave the patient alone, and remove all the hazardous and dangerous objects from the room. Even they are given disposable utensils, because in the past there have been scenarios where they cut themselves with glass. They break the glass and cut themselves, and somebody hanged them with their clothes. So you have to be there. You don't have to leave the patient alone. If the patient refuses to be hospitalized, complete form for involuntary admission. So against their will, you have to complete the form for involuntary admission, which is form number 1, and then you have to admit them. And you have to also, in Ontario, you have to give them form 30 just to notify them of their admission. And then if they're lower risk, I mean, they're not actively suicidal, but they have no active plan, they have no access to lethal means, but they do sometimes think that okay, they were better off dead. Then you can talk to them. Then the most important thing is you take them to, you refer them to psychotherapy, you explain them the safety plan, you discuss the protective factors with them, right? So protective factors: support in their life, remind them of what they live for, promote survival skills that help them through previous suicidal attempts. You make a safety plan with them that could include an agreement. An agreement, do you have to sign an agreement? No, it's just a verbal commitment. But you as a doctor, you would document. Not harm themselves, avoid alcohol, drugs, and situations that may trigger suicidal thoughts. Follow up is really important with you at this designated time. Contact a healthcare worker, call a crisis line, or go to emergency department if they feel unsafe or if their suicidal feelings return or intensify, right? So this is very important. You have to mention this to them, that you have to call a crisis line or you have to get back to the emergency department. Now we have different scenarios, that when to hospitalize and when not. So if the patient has suicidal ideation and they have depression, so with depression, so this comes first, right? Because mood disorders are most commonly associated with depression. So patients with depression, you have to consider hospitalizations if symptoms severe or if psychotic features are present. Otherwise, outpatient treatment with good support and pharmacotherapy. So if they have symptoms, their symptoms are severe, the depression is severe, and if they have psychotic features, they are also hallucinating, and they also do have some delusions. Their behavior is grossly disorganized. You feel like they are behaving bizarre. Then you can get them. You can hospitalize them. Otherwise, outpatient treatment. What treatment? Supports and pharmacotherapy. So you can start on antidepressants. Patient with alcohol or substance related issues. Suicidality usually resolves with abstinence for a few days, if not suspected depression. So, if they're misusing the substances, then if they abstain from them, the suicidality usually resolves. If it does not resolve, even after abstaining, even after quitting those substances or alcohol, then you have to suspect depression. Patients with personality disorders, you have may or may not hospitalize. So in borderline patients, you usually do not admit them. You just refer them to the case manager. You just give them like some psychotherapy, or you just help them out that way, where you don't really hospitalize them. So you just have to do crisis intervention, okay? Follow up with them, give them the crisis line, emergency department, refer them to the case manager and stuff like that. But usually they do not get hospitalized. Patients with schizophrenia psychosis, you have to hospitalize might be necessary. So with psychotic features, you're really scared, right? They might end up harming themselves. Patients with parasuicidal behavior, self-mutilations, like they do not have they do not have any suicidal self-injuries, but they have a few injuries, and they have a parasuicidal behavior. You just put them on long-term psychotherapy with brief crisis intervention when necessary. So whenever you feel like they're in really low phase, then brief crisis intervention. Otherwise, you do not have to hospitalize them. This is all about suicide ideation assessment. Asking patients about suicide will not give them the idea or the incentive to die by suicide, right? So remember this: if you ask them, that doesn't mean that you're giving them the idea. You have to ask them. The best predictor of completed suicide is a history of attempted suicide. So how can you predict that they can complete a suicide? History of attempted suicide. So previous attempts, highest risk factor. The most common psychiatric disorders associated with completed suicides are mood disorders and alcohol use disorders. So just what I mentioned here, with the mood disorders, add alcohol use disorders too. So that is why we had depression first and then alcohol. So if even on abstaining alcohol, if they still have those thoughts, then you can suspect depression. So mood is first, and then we have alcohol, substance use disorder, especially alcohol. So this one is second. Okay. Suicidal attempt. Patient comes to emergency department. Even if he denies treatment, treat him, as he came to the emergency for getting treated, of course. So you understand this because they came by themselves. He clearly not has capacity, no consent needed, even if someone else is bringing in. So if we say that there's a scenario in which the patient has suicidal attempt, and then they're saying that, okay, they're not giving you consent to treat them, what would you do? Would you treat them? Would you know, you'd say, okay, we don't have consent, okay, let's not treat. No, they clearly do not have capacity, you have to treat them. Even if someone else is bringing them in, and not even just like if they're coming by themselves, even if somebody else is bringing them in, then you have to treat them. Best protective factor against suicide is support, family connection, pregnancy, parenthood, religion. Risk of self-harm in adolescence: alert parents by breaking confidentiality. So if you feel like in adolescents there is a risk of self-harm, you can alert parents by breaking confidentiality. In this scenario, you would think that, okay, you cannot break their confidentiality, but if you feel like there is risk of self-harm, if you feel like they are actively suicidal, they do have ideations, and not even just suicide, they can just harm themselves, you have to alert the parents by breaking confidentiality. What to do when patient tells you he has access to gun in his home in heat of moment? Remove the access to mean. So that is what helps. So you have to start with telling them that you have to remove the access to the mean. So remove the guns, and this comes in the safety plan too, so you have to let them know. Avoid alcohol, drugs, and situations that may it should be here. No, not harm themselves. Okay, if it's not, but still this comes in the safety plan that you have to remove all access to any kind of lethal means. What to ask suicide attempt what to ask a patient who had suicide attempt when you discharge: how are you feeling? Okay, so when you're discharging, this is commonly related to NAC. So when you're discharging them, what do you ask? You ask them, how are you feeling? You get to know a lot by this question, how, because if they're feeling happy, just what I mentioned already, if they're feeling happy, that means that they're not going to do it again. But if they're sad, they'll attempt more. So you have to keep a close check on those people. Okay, psychotic disorders. Psychotic disorders have differential diagnosis of psychosis. It includes schizophrenia, schizophreniform, brief psychotic, schizoaffective, and delusional disorders. All right. Here. Psychotic disorders. So what happens in psychosis? There is significant impairment in reality testing. There is a test which is reality testing. You test if the patients are do they have an insight, or do they know what's the reality. So this is the reality testing, how far are they from the reality. So there is a significant impairment in reality testing in psychotic disorders. There are two types of symptoms: positive and negative. Positive symptoms includes delusions or hallucinations with or without insight into their pathological nature. So they might have insight, they might not have insight. Grossly disorganized or abnormal motor behaviors, including catatonia. Catatonia, they're just frozen. Formal thought disorder. So it's some thought problems. Grossly disorganized or abnormal motor behaviors, right? So delusion, hallucinations, grossly disorganized. The motor behaviors include like their general behavior, which includes catatonia, and then disorganized speech also includes in here. And then negative symptoms of schizophrenia. Negative symptoms means diminished emotional expression, affective flattening. The affect is flat. Anhedonia, not interested. Evolution, no motivation. Alogia, poverty of speech. Asociality, declining social interaction. So their social interaction declines. They're not as social as they used to be, right? Differential diagnosis of psychosis. There are these different psychotic disorders: brief psychotic, schizophreniform, schizophrenia, schizoaffective, delusional, substance-induced psychotic disorder, and secondary to mood disorder. We can have psychosis secondary to mood disorders also. Differentiate among psychotic disorders and distinguish them from primary diagnosis with psychotic features. So there are disorders which are psychotic themselves, so there are psychotic disorders, and then we have some other disorders like depression, which is the primary diagnosis, but they have some psychotic features along with them. So that would be depression with psychosis, that would be mania with psychosis, bipolar with psychosis, but that is a different thing. And psychotic disorders themselves, in which there's just psychosis, is different. Consider symptoms, persistence, and time. Symptoms: the primary diagnosis needs full criteria to be met. So we'll read the criteria in the DSM-5 diagnostic criteria. Mood: depressive episodes with psychotic features, manic episodes with psychotic features. Psychotic: consider symptoms in criterion A of schizophrenia. So if it is related to mood, the primary diagnosis is this, then it is mood with psychotic disorders. But if just psychotic, then criterion A should be met. Persistence: is there a time when certain symptoms clusters are present without other clusters? So if there is a time when they just have the mood symptoms, they just feel low, they just feel depressed, and then there comes a time when they just have psychosis, they hallucinate. So is there such thing? If there's a period of time with mood symptoms but not psychotic symptoms, consider mood disorder, right? So you have to see that which cluster of symptoms is the one which is persistent, then you will classify that as the primary diagnosis. So period of time with mood symptoms but not psychotic symptoms, consider mood disorder. If psychotic symptoms occur only with mood symptoms, consider mood disorder with psychotic features. So just mood symptoms, mood disorder, no psychosis. Psychotic symptoms occur only with mood symptoms, like when there is mood, they're feeling low and they're hallucinating also, then this is mood disorder with psychosis. And this is the difference between mood disorder with psychosis and schizoaffective, that if during a 2-week period where psychotic symptoms persist in the absence of mood symptoms, then we consider it schizoaffective. You understand? Like the mood disorder, like depression with psychosis, is a diagnosis, right, in which they will not have any period of time where they would not have depression. They will continuously have depression, and they might have like a few weeks, a few days of psychosis with it. But in schizoaffective, there will be absence of mood symptoms for a small duration of time, like during a 2-week period or more. So during two week period is in the DSM-5 criteria, so you have to remember. So for 2 weeks or more, they have psychotic symptoms persist, but the absence of mood symptoms. This is schizoaffective disorder. If long periods with psychotic symptoms and brief or rare mood symptoms, consider schizophrenia. So that is basically psychotic. So if they have the primary diagnosis would be schizophrenia when they have long periods of psychotic symptoms, but there is brief or some rare mood symptoms also. So this on the basis of persistence, we divide them. And then time, how long have the symptoms been present? On the basis of time, we divide them this way. This is a very good timeline. So if it is less than 1 month, it's brief psychotic. Brief psychotic usually is the one like postpartum psychosis, right? So brief psychotic stays for more than a day but less than a month, and it is usually triggered by something. It's not just coming out of the genetic part or just the biological thing. It usually is triggered just like postpartum psychosis or any trauma. So they have brief psychotic disorder, and this usually comes back to the baseline. After postpartum psychosis, they come back to the baseline. Schizophreniform disorder is 1 to 6 months. So it should be more than a month. They're feeling psychotic more than a month, but if it ends before 6 months, then we'll not classify it as schizophrenia. It would be schizophreniform, and if it is more than 6 months, then it would be schizophrenia. Okay. Then brief psychotic disorder, more than one positive symptoms of criterion A. So they mostly have positive symptoms. They do not have negative symptoms, because in here, when we'll read it again, brief psychotic disorder, criterion A1 to A4, D and E of schizophrenia are met for at least 1 day but less than 1 month. So criterion A1 to A4 is delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, but negative symptoms is not included in brief psychotic disorder. So they don't have anything like the alogia, asociality, evolution, anhedonia, because it's just 1 month. We may not, like, notice all of these, but they would definitely have the positive symptoms: delusions, hallucinations, disorganized speech, and grossly disorganized behavior. So that is what they're saying here. One positive symptoms or more than one, then it is brief psychotic disorder. Less than 1 month with eventual full return to premorbid functioning. So there is a full return in brief psychotic disorder, right? Which I've just mentioned. Schizophreniform criterion A is met for 1 to 6 months. Schizophrenia criterion A more than 6 months. Schizoaffective criterion A plus major mood episode, MDE or mania, it could be any, for more than 2 weeks of psychotic symptoms without the mood symptoms, and this should be more than 1 month. So when we are explaining schizoaffective, we just forget the timeline too. It should be more than 1 month. Delusional disorder, one or more delusions if hallucinations related to the delusion theme, more than 1 month. So delusion is also more than 1 month. What is a delusion? Delusion is a fixed false belief that are not amendable to change in light of conflicting evidence. So even if they have conflicting evidence, they do not change their belief. They have a fixed false belief which is not amendable. So this classifies as delusional disorder right here. And they usually do not hallucinate, but even if they're hallucinating, that is related to the delusional theme, right? And 1 month or longer. Schizoaffective 2, delusional hallucinations for 2 weeks. In total, does it say anywhere that it should be more than 1 month? Okay, I'll just quickly write more than 1 month. Yes, so delusion is more than 1 month too, and schizoaffective is more than 1 month too. Then substance-induced psychotic disorder. They might have delusions or hallucinations because of the substance they're using. Onset during an intoxication, withdrawal, resolve in less than 1 month without use. So when they'll stop using it, it would be resolved. Secondary to mood disorder, psychotic symptoms, mood symptoms dominant plus delusions or hallucinations. Mood congruent. So during the mood, it is usually dominant, but during those symptoms, the mood symptoms persist when they have delusions and hallucinations. So this is secondary to psychosis, secondary to mood disorder. So depression with psychosis, mania with psychosis. Psychosis may be present only for the duration of the mood episode. It might happen that just when they have the mood episode, they have hallucinations too. So it may be present only during that duration. Relevant investigations: CBC electrolytes, including extended electrolytes, creatinine, glucose, urinalysis. Urine drug screen is pretty important because you'll see in all the criterions there would be definitely one criteria in which they'd say, yes, the disturbance is not attributable to physiological effects of a substance, drug of abuse, medication, or any other medical condition. There would be definitely one point in which you have to meet that all the symptoms which the patient is presenting is not because of the substance abuse, is not because of any other medical condition or any medication. Disturbance is not attributable to effects of a substance or another medical condition. Similarly, wherever you'll find the DSM criteria, there would be the episode is not attributable to the physiological effects of a substance or another medical condition. So it is usually there. Why can I not see it in here? ABC. Okay, we'll come here in the next video. I'm sorry about that. Okay, so for ruling that out, you have to go for urine drug screen. So CBC, electrolytes, creatinine, glucose, urinalysis, urine drug screen. TSH is pretty important, especially ruling out depression. Vitamin B12. LFTs, fasting lipids, HbA1c to obtain baseline levels prior to the antipsychotic initiation. ECG, several antipsychotic Antipsychotics have effect on the cardiac conduction if clinically indicated, or the infectious workup, inflammatory markers, and brain imaging. So when there is a CDM, that when do you have to go for so here it's the medical workup of mood disorder. So there are two conditions, mood and anxiety. So during the mood disorders and the anxiety disorders, you need to do a full medical workup, which includes CBC, electrolytes, which is extended, LFT, renal and thyroid function, drug screen, medication list, B12. This is additional. So in older people, B12, because B12 deficiency would lead to depressive episodes also. Neurological consultations, chest X-ray, ECG, head imaging, and a complete physical exam. So you have to go for a complete medical workup. But if there is a CDM where they ask that, which is the one thing which you would definitely want to do in a patient where you're dealing with psychiatric disorders, that would be thyroid function test, TSH. Okay, right. Avoid physical this will come with the management. These are the differentials. Let's quickly go through the differentials. Hallucinations. What is this? Hallucinations? It is the perceptual experiences occurring without an external stimulus. There is no external stimulus, but there are perceptual experiences. Okay, the differentials of psychosis: primary psychotic disorder, schizophrenia, freniform, brief psychotic, schizoaffective, delusional. Mood disorder: MDD with psychotic features, bipolar, manic or depressive with psychotic features. Personality disorders: schizotypal, schizoid, borderline, paranoid, obsessive compulsive. They predispose to psychosis, but presence of psychotic symptoms require another diagnosis, but they are predisposed to psychosis, these personality disorders. But the presence of psychotic symptoms, if they have some psychotic symptoms, then that require another diagnosis. General medical conditions like tumor, head trauma, dementia, delirium, metabolic infection, stroke, temporal lobe biopsy, substance-induced psychosis, onset during intoxication or withdrawal, prescribed medications, toxins. So all of these are the substances which can induce psychosis, either the intoxication or the withdrawal, and then medication and toxins. Okay, schizophrenia. Schizophrenia, remember these words: loosening association of thoughts, lack of insight. So schizophrenia is associated with loosening association of thoughts. So now we have the DSM-5 criteria. Two or more of the following, each present for a significant portion of time during a 1 month period, or less if successfully treated. At least one of these must be 1, 2, or 3. So it should be any of these at least. So whenever you'll have a scenario, you'll definitely have some hallucinations or delusions or disorganized speech. So 1, 2, or 3, one of at least these, and then in total 2. So maybe a negative symptom, you'll see a flat effect on their face. They'll say that they're not motivated to work to do anything. They'll say that they don't socialize anymore, or they might be frozen in their behavior. In general, if you see them, you would find that their behavior is weird. It is grossly disorganized. So 2 of the following 5 symptoms, any 2, and then 1 should be from the 1, 2, and 3. For a significant portion of time since the onset of disturbance, level of functioning in 1 or more major areas. So level of functioning should be impaired markedly below the level achieved prior to the onset. So before the pre-morbid condition, the level which they had, it should be markedly below the level of the pre-morbid functioning in any of one major areas: work, personal, interpersonal relations, self-care, or academically, or occupational functioning. So the point DSM-5 criteria, the point B is that there should be significant impairment. Point C, continuous signs of the disturbance persist for at least 6 months. So we label it schizophrenia more than 6 months. So it should be at least 6 months. The 6-month period must include at least 1 month of symptoms that meet criterion A, that is active phase symptoms, and may include periods of prodromal or residual symptoms. So at least 1 month of the active phase symptoms, these are the active phase symptoms, and then they might have the prodromal or residual symptom periods. And during these prodromal or residual periods, the signs of disturbance may be manifested by only negative symptoms or by 2 or more symptoms listed in criterion A. present in an attenuated form. Example, odd beliefs, unusual perceptual experience. So when they have the prodromal or residual periods, the it during those periods they usually have the negative symptoms, or by two or more symptoms listed in the criterion A, but they're like little attenuated. They're not that bad like they were in the active phase symptoms, but there should be at least 6 month period. During the 6 month period there should be at least 1 month of symptoms that meet the criterion A, at least 1 month. This is options, the criterion C. Then we have schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out because either no major depressive or manic episodes have occurred concurrently with the active phase symptoms, or if mood episodes have occurred during the active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness, right? So you have to rule out that there is no mood disorder, there is no depression, there is no bipolar disorder, right? And even if there is schizoaffective disorder, so you have to rule out. So either they shouldn't be there, or if they are there, then they should be present for minority of the total duration. This is what we read over here too. Schizophrenia only for the duration of mood episodes. Somewhere we read, yeah, if long periods with psychotic symptoms and brief or rare mood symptoms, consider schizophrenia. So brief or rare, so they could be there but only minimal. That's what they explain in point D. For QE1, nobody's gonna ask you what is the DSM-5 criteria, explain these, list these, nothing like that, right? But it would be just that all of this would help you diagnose, right? The disturbance is not attributable to his physiological effects of a substance, example drug of abuse, medication, or any other medical condition. This is important and new. If there is a history of autism spectrum disorder or a communication disorder of childhood onset, so the patient they were on an autism spectrum disorder or some communication disorder, there was a history of that. Even if it is not present, there was a history. The additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are also present for at least 1 month or less if successfully treated. So if there is a history of autism spectrum disorder or any communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to other required symptoms of schizophrenia, are present for at least 1 month. So you can label them schizophrenic if they have prominent delusions. They were autistic, they had communication disorders, but if they had prominent hallucinations and delusions, and addition to other required symptoms of schizophrenia, like 2 or more of these, then they can be labeled as, for at least 1 month, then they can be diagnosed as schizophrenia. What are the specifiers? What is the type of episode? Is it first, or do they have multiple episodes, or is it continuous and an acute episode? If there was remission, was there catatonia? What is the severity? Epidemiology. So this is basically it. It is genetic, it is biological with the environmental factors, right? It is a multifactorial disorder, but it is equal in male and females. In females it occurs a little late, but in males it is early to mid-20s. And then they have a suicide risk. 5 to 6% die by suicide, 20% attempt suicide, so they do have a suicidal risk also. But we read that mood disorders and anxiety disorders are most common psychiatric disorders associated with completed suicide are mood disorders and alcohol use disorders. So they have 20% attempt suicide. So etiology, multifactorial disorder, result of interaction between both biological and environmental factors. This is important. They can ask these in MCQs. Genetic, 40% concordance in monozygotic twins. So if they are monozygotic, then 40% concordance. 46% if both parents have schizophrenia. So it could be, the possibility would be 46% if both the parents are schizophrenia, and 10% of dizygotic twin siblings children affected. So monozygotic more 40%, dizygotic 10%, parents 46%. You don't need to read this. Neurochemistry, what happens is basically excess activity in the mesolimbic dopamine pathway. So basically there's increased activity of dopamine. So that is why it is mediated by positive symptoms of psychosis, and then decreased dopamine in the prefrontal cortex that mediate the negative cognitive symptoms, right? So in the mesolimbic part there is increased uptake, so increased uptake in the limbic system but decreased uptake in the frontal. So because of the decreased uptake there are negative symptoms like the personality, the cognitive changes, the negative symptoms which we read, evolution, flat effect, and then anhedonia, alogia, because of the inhibition in the frontal lobe. And in the mesolimbic, there is excess activity which leads to positive symptoms. The excess activity leads to hallucinations, delusions, grossly disorganized behavior, and disorganized speech. Neuroanatomy: decreased frontal lobe function, asymmetric temporal limbic function, decreased basal ganglia function. So on SPECT, you will see that there is decreased uptake in frontal but increased uptake in limbic system, right? And then there might be, if the condition is pretty severe, there might be some CT scan changes also. And then neuroendocrinology, forget about it. Neuropsychology: global effects seen in attention, language, and memory suggest disrupted connectivity of neural networks. So there is neural network problem. So attention, language, and memory problems. Environmental: indirect evidence of cannabis use, maybe because maybe even when maybe the mother was using during the prenatal phase. So evidence of cannabis use, geographical variance, winter season of birth, obstetrical complications, prenatal viral exposure. So all of these do have impact on the schizophrenia. This includes the etiology. Pathophysiology: neurodegenerative theory. There is either rapid or gradual decline in function and ability to communicate. Glutamate system, you don't have to go into depth. And there's one neurodegenerative theory and neurodevelopmental theory, that there is abnormal development of brain from prenatal life. Neurons fail to migrate correctly and they have some inappropriate connection, and then they undergo apoptosis in later life. So this is basically the anatomical and endocrinal differences which happens during the schizophrenia. It's not that important, but whatever I've read, just keep that in mind. There are some disorganized behavior in schizophrenia: catatonic stupor, and then catatonic excitement. So in stupor, they're fully conscious but mute, unresponsive, immobile, and maintaining bizarre positions for a long time. But in catatonic excitement, they have uncontrolled or aimless motor activity, extreme agitation. So opposite thing. In here, they will be like immobile and unresponsive, but they are fully conscious. But they'll be in a bizarre position for a long time. But over here, they have aimless motor activity, excitement, stupor. Stereotypy: repeated but non-goal directed movements. They're just rocking, they're just banging their head, they're banging their hand. Repeated but non-goal directed movement. Stereotypy. Mannerisms: goal directed activities that are odd and out of context, that is grimacing. So they're just grimacing out of context, which looks odd. Echopraxia: imitate movements and gestures of others. So whatever they're looking at, they'll just keep on imitating the gestures and movements of others. Automatic obedience: carries out simple commands in robot-like fashion. So they are automatic obedience. This is called as automatic obedience. Negativism: refuses to cooperate with simple requests for no apparent reason. So they are negativism. They do not cooperate. Inappropriate affect: neglect of self-care, other odd behaviors, random shouting. So just disorganized, grossly disorganized catatonic behavior. Okay. Stereotypy mannerisms is just the repeated movements, which could be either non goal directed or goal directed. Echopraxia is imitating, and then obedience is whatever, if even if they follow. So this two are likewise, like usually they do not follow, they refuse to cooperate, they're negativism. But even if they carry out some simple commands, they act in a robot like fashion. And this is catatonic stupor, in which they are just immobile and in excitement. They're just okay. Comorbidity, substance use disorders, the anxiety disorders, and their life expectancy is reduced secondary to medical conditions. So in schizophrenia we don't usually discuss this thing, but this is pretty important, that they have increased risk of medical comorbidities like obesity, diabetes, metabolic syndrome, cardiovascular or pulmonary diseases. That is why they have reduced life expectancy. Let me just grab the charger. Alright, so in schizophrenia, they have reduced life expectancy because of increased medical comorbidities. And substance use disorders is related to schizophrenia, and anxiety disorders. 50% use tobacco. Okay, how will you manage the schizophrenia? So in psychiatry, whatever psychiatric disorders you're going to study, you're going to have to look into the management in such a way that if you have, like, usually there's three management. There's the pharmacotherapy, then the talk therapy, psychotherapy, which might include CBT usually, and then there is the social help, which you can provide them, the assertive community treatment. So you have to look into which one is given first in which conditions. So usually we go for like we start, at least in practical life, we start with psychotherapies first, but there are a few conditions in which you have to start them on medications. So in here you have to start them on medication. Schizophrenia, biological somatic comes first, then number 2 would be CBT, and third would be ACT, assertive community treatment. Biological somatic, acute treatment and maintenance on antipsychotics. They could be risperidone, aripiprazole, haloperidol, paliperidone, and if they are resistant, clozapine is very popular. That if they're resistant to any other medications, the patient who's resistant or who have like failed therapy for 2 or more than 2 antipsychotics, then they go to clozapine. Regimens of IM every 2 to 4 weeks. Long acting injectables for those people who do not are not compliant to shown long acting injectables or depot shown to be more effective in reducing relapse and rehospitalization compared with oral alternatives. So you can go for long acting injectables. So their regimens of IM every 2 to 4 weeks. So you'll come back in 2 weeks, you'll come back in a month. And then you can also go for adjunctive. So the pharmacotherapy is antipsychotics, and you can adjunct them with mood stabilizers. So mood stabilizers would just help with the aggression and the impulsiveness. Lithium, valproate, carbamazepine. So basically schizophrenia, psychosis, right? So go for antipsychotics, but you can adjunct it with mood stabilizers, or we can add anxiolytics or ECT, but these are the most important you have to remember. Then maintenance treatment for at least, if they had first episode, then at least maintain them for 1 to 2 years. But if there are multiple episodes, then at least 5 years after multiple episodes. Relapse cause severe deterioration, so whenever it comes back even worse. So you have to maintain the treatment. Psychosocial, psychotherapy, individual, family, group, supportive, CBT, ACT. So CBT is the second point, psychosocial, and then ACT, assertive community treatment, mobile mental health teams that provide individualized treatment in the community and help patients with medication adherence. So they are really bad with medication adherence. They feel a little better and then they stop the medication. So for that, there are mobile mental health teams. They go to their homes and provide them individualized treatment. basic living skills, social support, job placement, resources, social skill training, employment programs, disability benefits, housing, group home, boarding home, transitional home. Then you're gonna go for a course. So this is the management, course and prognosis. Majority in the management of schizophrenia, management of acute psychosis and mania. So you just have to have a quick look on this box. You have to ensure the safety of self, patient, and other patients. So if there is CDM in which you have to just pick one, it would be ensure the safety. So whenever you're going in, taking some history of a schizophrenic, like a psychotic or manic patient, you have to be closer to the door. You have to look through for your exit plan. You have to have an exit strategy. You have to ensure the safety. And then decrease stimulation. Don't ask so many questions, don't stimulate them. Assume a non-threatening stance. Then IM medications, benzodiazepines and antipsychotics. So you usually give them in one syringe. You give them antipsychotics and some benzodiazepines so their anxiety is controlled. And then often needed in patients who refuse the oral medication, you could just go IM. And then physical restraints, they should be avoided because they trigger them more. But if it is necessary, then you have to. Do not use antidepressants or stimulants. They're already stimulated. Psychosis, mania. So you're not giving them stimulants or you're not giving them antidepressants. You want them to calm down. So you're not giving them antidepressants so that they're stimulated again. So remember this thing. Schizophrenia, like psychosis or mania, you're not giving them antidepressants. You are giving them antipsychotics and even benzodiazepines. So over here we read antipsychotics and mood stabilizers, or anxiolytics like benzodiazepines. Alright, so this was important, and then there's no other side box which I feel it is important. Over here, this is very important for CTMs. What are the good prognostic factors? How would you say that? Okay, this patient has good prognostic factors. If there was acute onset, if it wasn't gradually build up. If it was acute, it is good. If the age of onset was late, it is good. It was not in their early adulthood. If it's late, it is good. The prodrome was shorter, good. Female gender, good prognosis. Good cognitive functioning, so their cognition is not affected. Good pre-morbid functioning. Before this happened, acutely, they were doing very well academically or occupationally, they were good. No family history, good. Presence of affective symptoms, good. Absence of structural brain abnormalities, no problems with the brain, good. Good response to drugs, good. Good support system, good. And if it was caused with stressors, by stressors, like there are specifiers in which we talk about with or without marked stressors. So if it was caused with stressors, it is good because that there is a trigger that caused it. But if it was without stressor, then that means there is some genetic or some familial thing. Course and prognosis, majority of the individuals display some type of prodromal phase, and then course is variable. Some individuals have exacerbations and remissions while others remain chronically ill. So accurate prediction of the long-term outcome is not possible. Positive symptoms typically diminish with treatment. This is important. So when you start treatment, you let them know that the delusions or hallucinations you're having, or you let their concerned family members know that the delusions, hallucinations which they're facing would be diminished, but the negative symptoms tend to be most persistent and cognitive symptoms may not improve. So the negative symptoms usually tend to be more persistent. They will still have the flat effect. They will still face a little bit of less motivation, but the positive symptoms which happen in the limbic pathway because of increased activity would be controlled, but because of the decreased activity of frontal, the negative symptoms that would be most persistent. Cognitive symptoms may not improve over time. 1/3 improve, 1/3 remain the same, and 1/3 even worse. Okay, schizophreniform. It is the same as schizophrenia, but episode of disorder lasts for more than 1 month but less than 6 months. If the symptoms have extended past 6 months, then it is schizophrenia. Specifiers, same thing. Prognostic factors, which was acute onset, confusion, perplexity, good premorbid conditioning, functioning, absence of blunt, flat affect, catatonia. So if specifiers are prognostic factors with catatonia, current severity. Treatment: schizophrenic similar to schizophrenia, antipsychotics, mood stabilizers with or without anxiolytics, with or without ECT, psychotherapy, and assertive community treatment. Then prognosis: it is better than schizophrenia. Schizophreniform is better than schizophrenia. Okay. um and then Schizophreniform is better than schizophrenia. Brief psychotic comes to the baseline. Premorbid, it comes back to the premorbid condition. Its prognosis is good. And the affective is between schizophrenia and mood disorder, so it is better than better than schizophrenia, but less like, a little bad, worse than mood disorders. So schizophrenia is like really bad. The prognosis is bad, worse than schizophrenia. Then schizophreniform is better, and then schizoaffective is in between schizophrenia and mood disorder. Brief psychotic disorder does not have negative symptoms. You will not see the negative symptoms in them. Negative symptoms diminished. So positive symptoms, they just wrote positive symptoms, right? They didn't say of schizophrenia, but negative symptoms of schizophrenia, because it's not happening in brief psychotic disorder. So it's not going to happen in every psychosis. It's mostly in schizophrenia. Diminished emotional expression, anhedonia, evolution, alogia, asociality. So we read this: 1 day to 1 month, eventual full return to premorbid condition, marked stressor, postpartum onset, catatonia. Stressful can occur after a stressful event or postpartum. So usually it occurs after stressful. There is a trigger for brief psychotic disorder. Yeah, if in the question they ask like one most important thing which you want to do in brief psychotic disorder, you have to keep them safe. So if there is postpartum psychosis, you have to pick one most important management: assure the safety of the baby. So treatment: secure safe environment. It is the most important. Antipsychotics, anxiolytics. So remember the antipsychotics. In brief psychotic disorder, we put them on antipsychotics. Good, self-limiting, should return back within 1 month. Then we have schizoaffective disorder. In schizoaffective disorder, it is more than 1 month. Delusional is also more than 1 month. We read it. There is an uninterrupted period of illness during which there is major mood episode concurrent with schizophrenia. But when schizophrenia happens, the criterion A happens: delusions or hallucinations for 2 or more weeks in the absence of major mood episode during the lifetime duration of illness. Symptoms that meet criteria for major mood episodes are present for majority of the total duration of the active and residual periods of illness. Disturbance is not attributable to the effects of a substance or other medical conditions. Specifiers: bipolar type, depressive type, catatonia, episode, type of episode, first episode, multiple episode, severity. So there would be persistent psychosis with intermittent mood episode. What is this? Persistent psychosis with intermittent mood episode. So they have mood episodes, uninterrupted period of illness during which there is major mood episode. Yeah, schizoaffective. So primarily you would say that there will be persistent psychosis, but there would be intermittent mood episodes. But when they have that psychosis, delusion or hallucination for 2 or more weeks in the absence of major mood episodes, they won't have mood episode during that time when they have those delusions or hallucinations. Epidemiology: 1/3 as prevalent as schizophrenia. Schizoaffective disorder, bipolar type, more common in young adults. So the mood disorder which they would have in between, in young people it's more of bipolar, but in older people it's more of depressive. Okay, young towards mania, bipolar, and old towards depressive. Depressive symptoms correlate with higher risk of suicide. Lifetime risk 5%. So this is what I told in the suicide too, right? That the depressive symptoms, the mood symptoms, majorly depression, correlated with higher risk of suicide. Schizoaffective, antipsychotics, mood stabilizers, or antidepressants. So we read that we don't really give antidepressants in psychosis and in mania. So over here it's written antidepressants, but usually we just stop like in antipsychotic, mood stabilizer. Okay. Delusions. What are delusions? Fixed false beliefs which are non-amendable even if we have some evidence. They could be non-bizarre, they could be bizarre. Bizarre are the ones which cannot occur in real life. They're just made up, being kidnapped by aliens, having one's organs stolen. But non-bizarre could occur, like somebody's in love with them, somebody is about to poison them, somebody is following them. These are non-bizarre delusions. So there could be present, the DSM is presence of one or more delusions with a duration of 1 month or longer. 1 month or longer, one or more delusions. It could be only one delusion also. Criterion A of schizophrenia has never been met, meaning they don't have schizophrenia. It's just delusion and purely delusion. But if they have hallucination, if they say that, oh, I can see somebody there, right? If they have hallucination, delusion is like fixed for a firm belief, right? But hallucination is like, even if without external stimulus, they have some perceptual experiences, right? They could say that, oh, there are ants on my whole body, they're crawling on me. So that is tactile hallucination. So if there are hallucinations, if they are present, they're not prominent, and they're related to the delusional theme. Whatever the delusion is, hallucinations follow that theme. Then it could be a delusional disorder. Apart from the impact of the delusion, functioning is not markedly impaired and behavior is not obviously bizarre or odd. So this helps you diagnose in scenarios that how would I, like, if we see that there's a patient with delusions and they might have a little bit of hallucination, you'd see, oh, what to pick, delusion or schizophrenia. So their functioning is not markedly impaired. Schizophrenia, it's markedly impaired. Look at point B, level of functioning in one or more major effect, significant portion of time since the onset of disorder, markedly below the level, right? So this is the difference, markedly below, but here it's not markedly impaired. If manic or major depressive episode, so if they have some mood episodes, they have been brief relative to the duration of delusional periods. So with this, you are differentiating it with schizophrenia, and with this you're differentiating with from schizoaffective, that if they had manic or depressive episodes, very brief relative to the duration of delusional disorders. The disturbance is not attributable to physiological effects of substance or any other medical conditions or any other medications, or is not better explained by any other mental disorder, not even any other mental disorders like schizophrenia. There are subtypes: erotomaniac, or somebody is in love with me, grandiose, or I am daughter of God. Jealous, persecutory, somebody's about to kill me, they're planning to kill me. Somatic, my body, oh, I don't have my hand on me, my hand is not attached to me anymore. Mixed, unspecified. Further specify bizarre type of episode is first or severity. Treatment: delusion, antipsychotics. Psychotherapy, but over here in delusions we start with psychotherapy. Number one is psychotherapy, then you go to antipsychotics and antidepressants. So antidepressants, we have seen in schizoaffective and delusion. Prognosis may respond well to antipsychotics, but patients refuse them and have chronic unremitting course. Some maintain a high level of functioning, some progress to schizophrenia. So they usually refuse the antipsychotics. So we start with psychotherapy in delusional disorder. Alright, that's about it from the psychotic and suicide. In the next video, I'm gonna go with mood disorders. Thank you.